Welcome, everyone. Thank you for joining us today for this outpatient-focused webinar hosted by Lumos Diagnostics as an antibiotic stewardship sponsor of the Urgent Care Association. Today's session will also feature real-world insights from WellStreet Urgent Care, one of the nation's leading urgent care organizations. My name is Amelia Stevens, and I'm the Global Marketing Consultant for Lumos Diagnostics. I'll be moderating today's session. Welcome. Today's webinar is titled Reducing Diagnostic Uncertainty, Rapid Evidence-Based Antibiotic Stewardship in Outpatient Care. Today's discussion will focus on stewardship solutions for outpatient settings, particularly during peak respiratory season when overlapping symptoms are heightened and patient volumes surge. We're also joined today by Annie Bell, Vice President of Medical Affairs at Lumos Diagnostics. Annie leads clinical strategy and clinical research for Lumos's rapid diagnostic technologies and has contributed to multiple peer-reviewed clinical studies on FebriDx. With expertise in clinical research, host-response biomarkers, infectious disease, respiratory diagnostics, and antimicrobial stewardship, Annie works closely with clinicians to evaluate and implement tools that improve diagnostic accuracy and patient outcomes. Today, Annie will walk us through the clinical evidence behind FebriDx and explain how rapid diagnostics can support evidence-based antibiotic decision-making during the initial patient visit. We're also joined today by Dr. Brian Bobb, Senior Medical Officer at WellStreet Urgent Care, one of the nation's leading urgent care networks. In his role, Dr. Bobb oversees quality improvement, provider education, and clinical pathway development across high-volume centers. His work focuses on reducing unnecessary antibiotic use, improving diagnostic confidence, and enhancing care consistency, especially during high-volume seasons. Today, Dr. Bobb will share real-world insights from WellStreet's implementation of FebriDx, including how rapid point-of-care testing was integrated into urgent care workflows. Together, our speakers will connect real-world urgent care experience with the clinical evidence behind rapid diagnostics and share practical insights on how antibiotic stewardship strategies can be implemented without disrupting workflow. With that, let's get started. Annie Bell is going to begin to walk us through with the global mortality and cost burden of antimicrobial resistance, setting the foundation for today's discussion on stewardship and outpatient care in the next slide. Thank you.
Thanks, everyone, for joining today. I know everyone has a busy day, so I appreciate your time and effort to be here. So unnecessary antibiotic use is driving antibiotic resistance. It leads to approximately 1.3 million deaths worldwide each year, and it affects every part of healthcare. In the US alone, you can advance. The resistant infections add over $20 billion in healthcare costs. This is straining the system through additional testing and adding time and complexity to already overburdened workflows. From a patient perspective, resistant infections lead to prolonged recovery times, loss of productivity, and often cause other negative health sequelae as a result of the impact of resistant infections. A major contributor to resistance is how often antibiotics are prescribed in acute respiratory infection. Things like coughs, sore throats, congestion are the most common reasons patients seek healthcare, oftentimes non-bacterial in origin, and do not need nor benefit from antibiotics. That said, over 50% of cases result in an antibiotic prescription. And a lot of that comes down to diagnostic uncertainty and patient expectation. So it can be difficult to differentiate bacterial from non-bacterial etiology in a short visit when signs and symptoms overlap. And there's also often an expectation by patients that they'll leave with an antibiotic regardless of the cause of their reason for presentation. And they don't necessarily appreciate that there can be negative effects associated with antibiotics when you don't need them. So together, those pressures are fueling unnecessary antibiotics, prescriptions, fueling resistance, and are adding to overall healthcare costs and preventable resistant infections.
Thank you, Annie, for walking us through the broader challenges and why stewardship matters in outpatient settings. Now we're going to narrow the conversation down to outpatient settings where providers feel these pressures every day, especially during high volume seasons like we find ourselves in right now. Dr. Brian Bobb will start us off with a quick poll so we can hear directly about the challenges you're facing day to day. Thank you.
As I'm sure you are all aware, we're in the middle of one of the busier flu seasons that we've had in a while, and I'm sure that you're facing these challenges. So we really want to get a sense of what you're seeing. I see people jumping into the poll already. What is that challenge? What is the biggest thing that you're facing in your centers? Obviously, the volume question is probably what a lot of us anticipate being one of the big drivers of stress and one of the biggest concerns for our clinicians. I see that one's popping up quite a bit, as well as the reason for this presentation, which is determining that bacterial versus non-bacterial etiology. And not surprisingly, we're seeing a lot of responses that kind of filter into those categories. So again, these are the questions that we look at. What are the biggest challenges? The difficulty in differentiating the bacterial versus non-bacterial, the high volume that we're facing during this season, and the unpredictability of which location might be hit harder on a given day, limited access to those diagnostics, and then the patient expectations. So we really wanted to touch on those things a little bit from what we have seen in our own experience and what I've seen over 20 plus years in the industry as well. If we move on to that next slide, we can talk a little bit about what kind of drove our decision to look into a tool like FebriDx and what pressures you all may be facing as well. As we all know, during this season, you were flexing up. We're seeing sometimes 40 to 60 respiratory patients per day per clinician. In some centers, that can be 3 or 4 times that much when you have the additional clinicians working there and the kind of pressure and chaos that can lead to. And then you have the goal of getting those patients cared for and giving them the kind of answers and confidence that you want to deliver at an efficient pace and based on what the expectations of retail medicine are. So you've got that 15, sometimes less minute time period to spend with the patient. And you're spending, over half of that time uncertain about what the diagnosis is and trying to figure out your next step. And, as I alluded to before, the point of care testing piece, we may be a little skewed to the higher end of that in the urgent care setting compared to the rest of the outpatient or ambulatory world. But there is some limitation there in what tools we have that are going to help us really definitively give the patient that answer so that we're not doing that fourth thing, which is guessing when we're prescribing and inappropriately adding antibiotics to the mix, or missing an opportunity to treat with an antiviral that might help for somebody who's in a high risk situation. So those are the sorts of challenges that we were considering when looking at this as an option. And I'd like to pass it back so that we can talk a little bit about what FebriDx is, and then we can get into what we saw in our setting within WellStreet and specifically within the Piedmont urgent care situation that we tested the product out in.
Thank you, Dr. Bobb, for walking us through the real-world pain points and challenges in outpatient settings. We're going to turn it back to Annie Bell, who's going to take us through FebriDx and its benefits for antibiotic stewardship.
So FebriDx is a rapid point-of-care immunoassay that aids in differentiating bacterial from non-bacterial etiology in patients who present with symptoms of acute respiratory infection. So as you can see here, it's an all-in-one integrated device that's instrument-free and delivers results after about 10 minutes. So it can be very helpful in the discussions right in the patient visit regarding the underlying cause of infection and maybe the best course of action in terms of treatment for that patient. So it serves as a visual tool to facilitate those discussions. FebriDx was evaluated in a large multi-center trial that compared FebriDx to a composite algorithm to determine diagnostic accuracy. FebriDx was found to have a sensitivity or a positive percent agreement, what you see here as PPA, of 93% and a negative predictive value of 99%. So it's very good at both detecting and ruling out bacterial infection. FebriDx is currently cleared for moderate to high complexity settings, and we have a CLIA waiver under review with the FDA currently. FebriDx works by using 2 host response biomarkers, so C-reactive protein, or CRP, and myxovirus resistance protein A, or MXA for short. CRP is a nonspecific acute phase protein that's upregulated in response to acute inflammation, including response to infection. So it's predominantly produced by the liver in response to inflammatory cytokines and assists in pathogen recognition. CRP has a fast induction time, which is relevant for this patient population as they may present early in their course of infection. And it's noted to be very sensitive. So you may know or have some experience with CRP already, and it's a very sensitive biomarker, but lacks specificity. MXA, on the other hand, is highly sensitive for viral infection. So it is part of the innate immune response to viral infection. It's upregulated in response to type 1 interferons, which are produced as a first line of defense in response to viruses. So it has both immune modulating and antiviral functions in the presence of a viral infection. And most, I guess, importantly and relevant to this conversation is it's not upregulated in bacterial infection. So it doesn't respond to the inflammatory cytokines that stimulate an inflammatory response to bacterial infection. And healthy individuals have very low levels of MXA. And it also has a quick induction time, much like CRP in that sense, so that if patients are presenting early in their course of disease, MXA should be elevated if there's a virus present. And so individually, these two biomarkers are neither sensitive nor specific enough to add diagnostic certainty to the conversation. However, when paired together, they have very good sensitivity and specificity for detecting and ruling out bacterial infection. So clinicians can have the conversation with confidence right in the patient's appointment about what's the underlying cause of infection and what's the best course of management in exactly their appointment. So Februex is very simple to use. It uses fingerstick blood in a very small amount, so 5 microliters. And like I said, the device is an all-in-one integrated device. It has Lancet, the blood collection tube, and buffers all integrated into the test, as well as the test strip. So the first thing we do, of course, is clean the finger and then remove in step 3, the protective green covering, which is covering the sterile lancet. And the lancet is just a small needle. It's not a blade. So it's very well tolerated by patients. And so we remove the protective lancet and lance the finger using the spring-loaded lancet, wipe away the first drop of blood. And then in step 5, we collect like a good drop of blood. So a good drop of blood will get you the 5 microliters. The blood collection tube works via capillary action. So as long as it's touching the blood, it'll draw it right down into the blood collection tube. And then once it's full, in step 8, we rotate the arm onto the test strip. And again, it's working by capillary action. So once the blood collection tube is in contact with the test strip, the blood releases onto the test strip. Once we verify that all has released, then we deliver the buffer by pressing the buffer release button. Buffer's integrated into the test. And then the blood and the buffer start to flow across the test, and results are ready in about 10 minutes. So the test is very easy to perform, very easy to interpret. So once the blood has cleared the test strip, and we verify that it's moved all the way across, then the test is ready to interpret. So the presence of a black-gray line, which is the CRP biomarker, and the blue control line is indicative of a bacterial infection. And notably, there's no red line there. So without MXA, that is lack of a viral host immune response. Any presence of a red line in the next section here is a non-bacterial etiology. And when the control line is there without any test line, that means there's no host immune response to either CRP or MX. And so this serves as like the visual tool that clinicians can use in the patient's visit to discuss the underlying cause of their presenting signs and symptoms and the best course of treatment recommendations that they have for the patient.
Just taking a step back from FebriDx, I mean, what we also always are trying to do, is to make sure that we are providing the best care, obviously, for our patients, giving our clinicians the best tools to work with. And so part of that is the education that we do ahead of time. So we want to make sure that there's robust by giving them the tools they need in the center, the rapid diagnostic tools, as well as educational tools to address the concerns of the patients that they see every day. And I'm sure that's in line with the group on the webinar today and what you all are thinking about. And in doing that, we found that standardizing pathways across the clinics helps us to maintain consistency, helps us to manage flow during high volume times. And then by doing things in a systematic way, we therefore also generate a lot of data that we can analyze about how things work, to look at that in the kind of post-mortem period, if you will, after visits and after respiratory season, to see how we did and evaluate that process and look for ways to improve. So when we think about that, we want to really look at that feedback that we're getting from the clinicians, the feedback that patients are giving us, looking at quality metrics and the data to understand the challenges that we're facing. And then we want to target programming and other content to really hone in on the clinical skills for our clinicians to make sure that they are, getting the latest information and feel comfortable and confident with how they approach things in the room with the patients and in the centers with the staff. Part of doing that is then to look at, okay, we've established what these needs are. Let's evaluate what tools are out there on the market, and things are available to us that we may not have had even just a few years ago to help us, along with our clinical training and experience, to give the best recommendations and provide the best treatment for our patients. And once we have those tools in place, we want to adopt protocols to apply those best practices and, to kind of walk us through that initial patient contact all the way through to discharge in, a systematic way, and then engage the clinical teams in getting that feedback. So, all of this comes together for, a myriad of the different problems we face. But clearly, in urgent care, respiratory season is kind of our playoffs and Super Bowl season, if you will. And that's always when things are at their busiest. And it's one of the primary roles that we hold in the healthcare community, is helping with those surges that we see, certainly during this time of year, but as we've seen with COVID, that occur throughout the year, and how we differentiate different illnesses that come into play. As we were looking at, again, antibiotic stewardship, making sure that we're doing the best for our teams and for our patients, then we determined that product like this would be useful. And the question became, okay, how are we going to implement this? What would be the best way to approach our teams, again, by getting the understanding of where their pain points were and having discussion with the clinicians ahead of time? I think it really smooths over any concerns people have about a new test, or where does this fit into my workflow? So with FebriDx as it is now, as we await the CLIA waiver, we needed to find a spot that it would work for us with a moderate complexity lab. And we had an opportunity in one of our busy clinics to do that. And because of that part of the workflow, and because we were evaluating, we took a little bit different approach than what I'll kind of share with you on the next slide. So, we started with, okay, what's this need to look like for us to really evaluate this? We want to check the patient in, we want to understand what their symptoms are, and then have a clinician involved early on, so that, again, we're getting good sense of what the situation is for the patient and how FebriDx or a test like this could fit in. And so we did this at the triage stage, when you understand a little bit of what's going on. We can get the test running. Again, in 10 minutes, you have an answer. Is it bacterial? Is it non-bacterial? And then the clinician is able to come back and think through clinically, okay, do we have the answer that we need based on what we've seen? Do we need to consider other testing, whether it be rapid antigen testing for strep or COVID or flu, or if this is a more severe case or a more complicated diagnostic picture, would advanced PCR panel be helpful? Are there other diagnostics that need to come into play? X-ray, other things that you may have in your clinic. What we've seen with that is, adoption was not a question at all. Our clinicians really saw pretty quickly the value in having that determination between bacterial and non-bacterial available to them early in the visit. It did help to differentiate where we might go with additional testing if needed, and it really gave our patients a confidence in the diagnosis they received. So what we're looking at for our next stage, as we get to that CLIA waived status and expand this, is to really put more of a standing order pathway into play, so that when a patient comes in with an acute respiratory complaint, cough, sore throat, fever, congestion, our CSRs, who are our MAs, do that quick evaluation. As they're doing the intake, they go ahead and run the test, and as simply as Annie just described, get the test going and have that 10-minute time frame while they're finishing up the triage and intake portion to get the result in, and have the clinician then consider the intake information, those results, often decide then before entering the room, okay, are there other tests we need to consider? And that, again, helps you to just manage that workflow in the clinic when you're dealing with these high volume days. Then going in, again, having that piece of information in front of you. Are we dealing with a bacterial illness? If so, do I need additional testing, or do I know now what treatment I need to prescribe? Or if it's non-bacterial, okay, what other diagnoses do I need to be considering? Again, are there other tests to consider? Are there antivirals I should be considering? And in all of this, what other resources do I need to employ, whether it be, just prescribing and clinical guidance, or is there, follow-up treatment that needs to occur on the symptoms that are there? So FebriDx is really giving us, an early look at, early in the terms of the visit, at what pathway we might be going down, and helping the clinician to really think ahead and move efficiently through the process. When we think about not just what the patient experiences, but also from the clinician standpoint, taking out a lot of the uncertainty and the guesswork and the explaining the possibilities before you have an answer to a patient, as opposed to coming in with a little bit more confidence of, okay, we're heading down this pathway versus another. I mean, a lot of that just gives our clinicians a little bit more of a confidence going into the wrap up of the visit. And I think has helped a lot with some of the burnout that can occur during this time when you have just all of this uncertainty all of the time. So by taking that out, we've seen that group that's been working with the FebriDx product feel that increased confidence and comfort with the diagnostic process. So I know there's a lot to kind of explain where we've been, what we've looked at to date, and where we see this going. But honestly, going into it, as I said, we kind of evaluate these tools and think about, okay, how's this going to work? What's this pilot going to look like? And we go into it with different expectations. And honestly, this question of, okay, well, how does this fit in with other tools that we have? And is this going to be something that clinicians are going to really value? And what we did see was there weren't a lot of those questions about why are we doing this or where does this fit in, but it was more excitement to use it. How can we make this more streamlined? How can we get the answer even earlier on in the visit? So it pretty quickly became clear to us that this is something that's going to be a useful tool for us in the long run.
Thank you, Dr. Bobb and Annie, for the valuable overview of antibiotic stewardship best practices, as well as overview of FebriDx and implementation at WellStreet Urgent Care. We've gotten some great questions in the chat, so we're going to move right ahead to the Q&A section. I'm going to get started. There's a great question for Dr. Bobb. Did you have any barriers to adoption, and how did you handle these? What outcomes are you seeing from initial adoption for FebriDx?
We kind of anticipated that there might be more resistance to just a new test and how do we fit this into the workflow than we saw. But that being said, I think the way that we approached it and probably the reason we didn't see as much of that outside of just the utility of the test being pretty clear was laying the groundwork early and really, going back to kind of our approach with involving clinicians in these decisions. I think that by having plenty of discussion in advance about the why and the kind of the goal of bringing something like this in, it opened the floor for the clinicians to really kind of drive the use a little bit and to feel like they were championing something. I think that as we look at this at a bigger scale, that involvement piece may be a little bit less because it's not a pilot, but it's the kind of the discussion about how it's been implemented, what we've seen in other places as far as when we roll it out to our other clinics. And I think that ties into the second part of the question about outcomes from the adoption. And I think what we're seeing is that, again, people feel confident about a decision not to prescribe. I think a lot of times, there's that hesitancy, there's that, oh, am I going to get pushback from my patient on whether I still need an antibiotic or not. And, sometimes that may be mitigated through wait and see antibiotic prescribing and things along those lines. What we've seen with this is that, the clinician has the confidence to go in and say, look, this isn't a bacterial infection. We've got that initial FebriDx that helped us to determine that along with the clinical scenario and any additional testing, and we can feel confident that this is the road we should go down. And so we've seen that prescribing rate come down because of that, and the patient satisfaction side of it has actually been impeded. Like we have not seen a change there at all with the great NPS scores that we see in that clinic. And on the patient side, where a lot of people now, I think 5, 10, 15 years ago, there was a lot more, we always expect an antibiotic, and that's true, that's still there. There's also the group that's like, I don't want an antibiotic unless I know that it's necessary. And so being able to tell somebody, hey, we have this result that says it is bacterial and you do need the antibiotic can be sometimes just as important as being able to say this isn't bacterial and you don't need the antibiotic. So I think that confidence has been a real big boost for our clinicians, and it's probably been a big piece of why the adoption has been as smooth as it has.
I have another question for you. This is a great one. In your urgent care center, is the triage done by the clinician seeing the patient or with a nurse or medical assistant? Who is the first person to see the patient?
From the way I presented that, it might have seemed a little confusing. Medical assistant is absolutely the first person doing the intake. During the pilot period, we would involve the clinician once somebody was identified to have respiratory symptoms that would fit the scope for FebriDx, just so that we could determine whether it was appropriate to use it, make sure the clinician felt comfortable out of the gate. And I think that does, again, going back to the first question, help with the adoption a little bit early on because the clinicians were involved. But what quickly the feedback we got was, look, this is great. Now that we understand how this test works, we really want that to be part of this kind of workflow where the MA is, has the standing order ability to go ahead and order that under certain circumstances. Now, that being said, there's going to still be times where a test doesn't fit into a standing order protocol and you don't feel comfortable having your MA going ahead and running it, but you would still be able to add it on. And because it's such a fast test, it really still doesn't impede the clinic workflow and the pace that the clinicians expect.
Appreciate that. The next question that we have is, can you explain your clinical thinking on using the FebriDx test before you do a COVID flu test?
Again, there may be circumstances where COVID or flu is high in the, in the community, and you might change your guidance, but there's always that question that patients are going to have about, bacterial or not. There's also the question that arises, even though it's unlikely, of co-infection. And so I think this is another tool there. I mean, rarely is that going to be, the issue, for the patient, but it does, give you another piece of information there. Having that bacterial, non-bacterial kind of determination early on has really helped us to narrow down the pathway a bit. Again, if what you're seeing is all flu, you may make a choice to differently in your clinic. But when you have that negative or that indeterminate and you're seeing somebody in front of you that has symptoms and they're going to want to know, okay, well, you're telling me it's not flu, everyone else has flu, so then what is it? That's where you still may want to use the test. So I think that there are different ways to apply it. Again, when we started the pilot on this, it was before the flu season was in full swing. And so we were seeing more of a mix of different respiratory viruses along with the bacterial, components, and having that flexibility of having, a bacterial versus non-bacterial track was very important.
That brings us to our next question for Annie. Could CRP inflammation be elevated due to other chronic or comorbid conditions and therefore cause a false positive result?
CRP, so many people can have an elevated CRP due to other comorbid conditions or underlying inflammation or procedures that they've had, injuries that they've had. However, it's typically below the level of detection on our test. So our test is designed with this in mind, and the limit of detection is around 20, whereas most underlying inflammation that is not due to bacterial infection would be below 10. And so the test is designed to exclude that noise and is only identifying inflammation that is going to be elevated likely due to an infection. That's how the test is intended to be utilized.
What is the cost of this test?
It averages between $25 and $30 per test.
And what is the CPT code and reimbursement rate for FebriDx?
So FebriDx has a PLA code, which is a proprietary laboratory analysis code. It's 0042U as an umbrella, and it's at $41.38.
And how does FebriDx compare to a test like procalcitonin?
So procalcitonin uses serum or plasma, typically venipuncture or drawn off a line if you're in the hospital, and needs to be spun down and used in a laboratory. So it's not necessarily utilized within the patient visit like FebriDx can be. So procalcitonin is not a point of care test. Additionally, what upregulates procalcitonin is the presence of a cytokine response in relation to bacterial infection. And that it's a host immune response biomarker to that. So it doesn't have the added benefit of the MXA, where you could reliably differentiate between the bacterial and non-bacterial etiologies that most likely cause a respiratory infection. Calcitonin is often more utilized in more systemic infections in the hospital setting.
Thank you, Annie. A question on timing around this test. Any timing of symptoms on results, given some antigen or PCR respiratory tests may struggle on day 0 or the first day of symptoms, but then subsequently turn positive on the next day as a pathogen load increases above an LOD.
I can take this from the test perspective, and Dr. Bobb, maybe I'll turn it to you from the clinical perspective. But as I mentioned earlier, both CRP and MXA have very rapid induction times. So as the pathogen is present, the host immune response induction time is very quick. And so if the body's having that response, FebriDx should pick it up very early in the course of disease. And then if that response is sustained, then it continues to be positive. So in terms of day 1 versus day 3, it's really dependent on the individual's host response. And that's what makes this test have so much clinical utility. So Dr. Bobb and I might have the exact same pathogen. We both might be having flu A and got it from the same person on the same day, but we have different underlying host immune response that would be reflected by the test. And it's not necessarily time dependent, but dependent on our prior exposure to that pathogen, dependent on our underlying wellness and comorbid conditions. And so it's not necessarily time dependent, but your body's ability to mount that host immune response that is relevant to FebriDx and helps make it very patient specific. So I don't know, Dr. Bobb, if you're experiencing how you've experienced that when patients come in first, like on their first day of their illness versus having it for about a week. Are you experiencing any difference in how you utilize the test or how your clinicians are interpreting the test?
I think it goes back to the earlier question about why to choose this over maybe sometimes the antigen tests, out of a gate, and just knowing again that you're going to be more likely, if someone's coming in to the point where they're having symptoms, you're more likely that you're going to at least get some guidance on whether you're early bacterial versus, an early non-bacterial illness. So, to me, that's the utility there. Often, when you have something that is a little bit more ambiguous, you're going to pair that with some other testing to hone in, and then your clinical skills are going to, come into play in determining what your treatment is. But this tool really gives you a lot more confidence in that pathway that you're going down. And again, the quick response, again, the fact that we're not looking for a specific antigen, but we have, this response that's related to whether the body is mounting a defense against a bacterial versus a non-bacterial pathogen really helps us to use the clinical skills in those more ambiguous cases.
And that brings up a good point, actually, that pathogen agnostic. So it's measuring the host immune response as opposed to a specific pathogen. So it's great that clinicians have access generally to both type of tests because they're answering different questions at potentially at different times in the course of disease. So two very different technologies, but offering useful information.
I have a next question. We're getting some great questions in this chat. Based on the nature of the test result is dependent on host immune response. The study exclusion criteria included antibiotic use, antiviral agents, interferon therapy, immunosuppressive therapy, or a live viral immunization within the past 30 days. Is this anticipated final recommendation?
The inclusion criteria is in the package insert. So it's noted that those patients were excluded from the study. So it's not necessarily a recommendation, but a notation that patients who are immunocompromised were not included in the study validating FebriDx.
Our next question, when will FebriDx get CLIA approval?
We're currently on the, anticipated timeline for being granted a CLIA waiver. So we submitted late last year. Within the 90 days, the FDA came back to us with their response, and now we're in discussions with them. And so we anticipate being granted that waiver in the first quarter here. So,
how was the current age range for FebriDx determined, and are there plans to lower it?
We are conducting a study currently to reduce the age down to 2 years of age. That study is currently enrolling, and we'll have more updates as the data comes in.
The next question is, what if we have a patient with both strep and influenza? What would the result look like on FebriDx? Is it still going to show the gray, blue, and red lines? If I went down your algorithm and did FebriDx first and then swabbed based on the results, may I potentially miss strep?
So the test again, is representing the host immune response to the bacterial or non-bacterial etiology. Although you may be able on some of the other technologies, especially PCR, to detect both strep and influenza, the likelihood that you're having a host immune response at the same exact time is relatively low. So our data shows that basically what you're asking about here is co-infection, that the likelihood of co-infection in this outpatient setting and acute respiratory infection is low. Even though it's on the radar in terms of the differential diagnosis, the actual two host immune responses at the same time are generally uncommon. That said, if you truly did have a co-infection, you would likely have a result, as you noted, the blue line, the MXA line, which is red, and then the the gray CRP line. And so in that, as Dr. Bobb was mentioning earlier, you need to, if a co-infection is on your radar, and patients are at risk for that and have other, comorbid conditions or other considerations that make that high risk, then definitely use your clinical judgment to make those decisions. Dr. Bobb, maybe you could elaborate on that.
That's where this test is going to be helpful for you because, again, if you get a definitive it's bacterial, definitive non-bacterial, then you're able to guide any additional testing if you even need it. I mean, if you know you already have an exposure, you're in the flu season, you get a non-bacterial, everything looks that way, you may decide, I'm going to, treat and recommend based on that. Or similarly, if you have somebody who has an in-home exposure to strep and you don't feel like you're going to need a confirmatory test and you're going to treat, that's going to be your clinical decision. I think, though, when you get that mixed result, it's giving you the confidence to say, okay, I need to think about co-infection. It's very rare. I mean, it's always something that's on our mind, but when we look at it, it's such a small percentage of the patients that we actually see that do truly have the co-infection at that time of presentation. But again, the advantage of having this test is now, okay, I've gotten a result that tells me that that should be a little bit higher on my kind of list, and my radar should be kind of going off a little bit. And so now I'm going to think clinically, okay, based on what I see in front of me, based on the history, do I need to do, some additional testing? Is it more than just one additional test that I need to do to give me confidence and to give my patient confidence in those next steps? Again, what this is helping you do is to isolate those times when you need to do that and really rule out a lot of the times that you don't. And so, that predominance of the time when you're not doing that, you're saving that time, money for the patient, all of that by having those answers, and then feeling really good at the times when you do decide you need that extra testing, that you're not wasting resources or time, and that you're really giving the value to the patient.
Thank you, Dr. Bobb and Annie, for answering those questions and for this presentation. And thank you again to everyone on this call for taking the time out of your busy schedules to listen about FebriDx and antibiotic stewardship best practices. This is all the time that we had for today, and it has been incredibly valuable. As we wrap up today, I want to take a moment to bring it back to why this conversation matters. Across outpatient settings, diagnostic uncertainty during respiratory season can be the norm, not because clinicians lack expertise, but because they're being asked to make high-stake decisions under intense time pressure and without actionable data during that initial patient visit. What you heard today shows that it doesn't have to be the case. With FebriDx, providers can move from uncertainty to clarity during the initial visit using a simple fingerstick blood sample and a 99% negative predictive value for bacterial infections. That means more confident decisions, improved patient management, and fewer unnecessary antibiotics. Many of you have already taken the next step and booked up follow-up conversations with our team to explore in FebriDx. Thank you again for spending your time with us today. We look forward to connecting with many of you and continuing this valuable conversation about antibiotic stewardship in 2026. Have a great day.